here today with Dr. Amy Hartsfield from TMJ Sleep Solutions of Alabama. They help people who are dealing with things like chronic facial pain, headaches, sleep issues, fatigue, and on, right? Anything
Yes.
related to those things, who are looking for answers to this problem and are having trouble finding what's going on. So we're going to do a whole series of videos kind of based around these topics. And our first one is beyond TMJ disorder. So we are going to look at that, but we're also going to go a little bit past that. And this is what an orofacial pain specialist treats. So before we really dive into this, I would love to hear a little bit about just kind of your background and how you got into this role as a doctor, sort of what made you want to, and I'm sure this is a bigger story, but what made you kind of want to get into this and how did it happen?
Yeah, thank you so much for having me. I started as a general dentist. So my background is dentistry. And I practiced general dentistry for 13 years.
Mhm.
But when I came out of dental school and started practicing, I was started to be struck by chronic pain syndrome that nobody could figure out. And I had migraines, headaches, TMJ disorder, fatigue. And so I went back and specialized at the time and became a specialist in 2018.
Okay.
And that it was recognized as a dental specialty in 2020 amidst the lockdown. So nobody really knows what an orofacial pain specialist is. I mean, and I'm the only one in Alabama. So, but yes, that's kind of what brought me to it. I fixed myself, and then I was there to fix others.
You're the only one in Alabama.
Yes,
That feels like a big deal.
I guess I don't know. I mean, I'm sure there'll be more. It's just it's a newer specialty. I mean, the orofacial pain, Academy has been around for a long time, but it took a long time for them to be recognized by American Dental Association.
Okay. Okay. That's really interesting. Wow. Okay. So tell me, let's start with this. What is the difference between TMJ and TMJ disorder? Because I will be the first to admit I didn't know there was a difference. So tell me.
So, I mean, it's simple. Like I tell people, everybody has TMJ. I mean, you have two joints right there, but the disorder is when they have the pain associated with it. So it's not, I don't want to correct patients because it makes them sound, not like they don't know what they're talking about, but it's TMJ disorder, or we call it TMD sometimes, TMJD, but TMJ is actually the joint itself.
So what does that stand for, TMJ?
Temporomandibular joint.
So that is just the name of that part of the body. Okay.
Yes.
Okay, that makes sense. And so talk to me about, as an orofacial pain specialist, what do you do? What does your day look like?
So I I'm actually dual boarded in orofacial pain and dental sleep medicine. So I treat sleep and pain patients. So it's not just people. I name my practice TMJ because everybody it's almost like the fibromyalgia of the face. I mean, it's kind of a blanket thing, but we treat TMJ disorder, migraines, toothaches that aren't toothaches, earaches that aren't earaches, neck pain, also trigeminal neuralgia and trigeminal neuropathy. So like weird nerve pains of the face.
Okay.
It's kind of a double-edged sword naming your practice that, because like I have my periodontist who they're not going to send me TMJ disorder. They're going to send me the toothache that's not the toothache, or trigeminal neuralgia. And then the patient gets confused to come into the practice because they're like, why am I going to somebody that specializes in TMJ disorder?
Yeah.
However, if you go to the ENT, like if they don't see anything going on with your ear, the ear canal and the joint is so closely related, and it's just separated by the thinnest bone in our skull.
Okay.
And so a lot of times it'll refer pain to the ear, but they'll just say, oh, it's TMJ disorder. What actually may not be TMJ disorder. So sometimes it is like sometimes could be an autoimmune disorder of the ear that the ENT can't catch on. And so we take blood work and look at all like autoimmune markers and things like that, trying to figure out what it is and help the ENT get this patient better.
Wow. That's amazing. So talk to me a little bit more. You've named sort of some of the symptoms that you see related to these kind of things. Can you talk a little bit more about specific symptoms that people come to you with and kind of what that can look like for them?
Well, basically most people know that they have migraines, but a lot of them do not know that they have migraines.
Okay.
And so they'll have headaches, or they'll feel the joint pain. And some people think a lot of things are sinuses. So maybe they'll go to the ENT and say, it's my sinuses.
Right.
And the ENT says it's not your sinus, and so I may see them and point out to them, just because a weather change happens doesn't make it your sinuses. basically migraines are affected by barometric pressure. So they may feel it in their sinuses. Some people that have TMJ disorder don't think about it. And this is kind of complicated to explain, but we have a trigeminal nerve. Is basically the nerve I work with the most. Okay. And so it has 3 branches. It's like 1, 2, and 3.
Okay.
And so people that have migraines think about, it being here across the forehead or anything like that, even all the way to the back of the head, because that nerve feeds all the way back to here. Okay. But also what they don't think about is the 3rd branch. And so that 3rd branch is what feeds your joint. And these 2 branches are sensory. That's kind of hard. I guess I'm going a little bit neurological on you,
okay,
but you feel things in these.
Okay.
This one is, you feel it, but also it has motor component. So some people, when you get their migraines under control, their TMJ disorder gets better. So their jaw doesn't lock up because it's just that nerve sending a signal down to that jaw.
Okay.
But sometimes they have just actually TMJ disorder and they have a disorder of it with the disc and everything. And so therefore they have to fix that plus the migraine. But there's like a wonderful excerpt from a migraine, our journal basically that we have from in the migraine world. And it came out of 2018 about like how much like TMJ disorder can affect migraine, and sleep. And so he talks about sleep and migraine, and also like even having TMJ disorder leads to more migraine. Oh, wow. So we're just trying to differentiate between that. Other things may be like neuropathic pain of the face. I mean, like trigeminal neuralgia is a horrible thing. Gosh. And so people will have the firing of that nerve, and it's like they go and stick their finger in an electric socket for a few seconds, and then it goes away. They actually will have what's called a refractory period. They'll touch an area that'll actually trigger it, and then it'll fire. And then if they go to touch it again, they can't feel it for a little bit, and then so that's where I have to differentiate between that and what's called a neuropathy. So if they're, that's like a shocking pain. You can have a trigeminal neuropathy, which is basically just dull aching pain of that nerve versus like a sharp pain.
Yeah.
So a lot of times patients get misdiagnosed by a lot of neurologists and things with trigeminal neuralgia. And we have certain drugs that we use for trigeminal neuralgia, and then we have certain drugs that we use for trigeminal neuropathy and treatments. And so a lot of times people will end up with getting diagnosed with trigeminal neuropathy, and they're not getting neuralgia, and they're not getting any better. And the reason why is because they're missing that it's a neuropathy.
Okay.
So
can you go into just a little bit of the difference between neuralgia and neuropathy?
Sure. So the thing I like to explain, it's again, like the light socket. Like it is a sharp, shocking pain. On that. And then also where the neuropathy is like that dull aching pain. But I tell people like they would never think about that. You have to think about like a diabetic neuropathy. If you ever have a diabetic and they have it in their legs. Yeah. I mean, it's just a dull, aching, throbbing pain. Okay. And so that's a totally different, like basically like how they quantify like pain or whatever. How they, I guess justify what it is and the symptoms that it has. Yeah.
Okay. So with all of these different components, migraines, headaches, earaches, neuropathic facial pain, occipital neuralgia, how can they all show up together?
Really, I feel like it's not always the case, but a lot of times it's an autoimmune response. Okay. So that's where, like, it's not just me, and I'm not the doctor that provides all the care. Like I tell people all the time, I'm trying to get to the source of the problem. Right. So, like I go and like look at blood work and find out what all's going on. But you'll find a lot of those kind of were within autoimmune conditions. Like for instance, I mean, people don't think about diabetes, but it's an autoimmune condition. So when you go and have a neuropathy, I'm looking for like insulin resistance and things like that. But a neuropathy actually can happen without that. Neuropathy can happen actually from trauma. Oh. So we call that post-traumatic trigeminal neuropathy, or PTTN for short. Okay. That happens like with a blow to the face. Okay. Or it can happen after a dental procedure. Wow. And so it's very rare that it happens, but it can happen. And it's sad, because it's not the the provider's fault. It's not the
Right.
dentist's fault. It's not the oral surgeon's fault. It's not the endodontist or any of the
Yeah.
specialists. But it's just a thing that can happen. It can happen even with the numbing of a patient.
Really?
So yes.
Wow.
But I tell people all the time, it's like you were predisposed. I mean,
Okay.
minus a trauma. Like, I mean,
Yeah.
if you're having traumatic jaw surgery or something like that, that's a whole different story. But it is kind of like somebody that was going to be predisposed. They have other
Okay.
things going on.
Okay,
You know,
okay.
so I have a lot of autoimmune patients, and so
Yeah.
I work with their other physicians trying to
Right.
get them the care that they need. Like they may have a rheumatologist or, their primary care physician, and I, or the ENT or whatever. And so we get to kind of to the bottom of it.
Okay.
So
Yeah.
like, kind of, for instance, I'll give an example of kind of a rare one. I had a patient that I really was determined that it was trigeminal neuropathy for
Okay.
a while. And it was basically, she never had problems. She had extraction of her tooth and had a bridge for years.
Mhm.
And she actually went up into an airplane. And when she went in the airplane, she started having pain in the area of that tooth that had been extracted years before, which didn't make sense to me at all. And so we went through and checked everything. And I mean, I kind of like a little, basically detective, trying to pull back all the layers of what happened. And so that one took me a long time to figure out, but it took finally getting images from her dentist after we had been trying to search for the answers. And the dentist had just bought a practice, but lo and behold, she was like, did I, not show you this image? And so it was that there was a fistula, basically a hole in her sinus that the dentist had found when they had replaced the bridge at one time.
Wow.
And so with that, I did what's called a CBCT, a cone beam CT that we have in our office. And we revealed there's something was in her sinuses. So going into that, I had to send her back to the ENT that sent her to me, and there was a fungal infection, like actually a
No
piece that
way.
he had to go have surgically removed out of her sinus. And it had just kind of been communicating from her mouth. I mean, what's here is not supposed to be
Sure.
here, in her sinuses. So it had just been communicating and building up over the
Oh,
years.
my
So she had to have
goodness.
surgery. So, I mean, that's kind of an extreme case, but there are a lot of
Yeah.
cases like that where I have to just kind of figure out what all's going
Yeah.
on. And maybe like I have to get imaging, or I have to get previous imaging or previous notes.
Yes.
And sometimes just kind of do some investigating on it.
Yeah.
Yeah.
That's fascinating.
Thanks. I love it. I do love it. Yeah.
So all of these things, you also have sleep solutions in the name of your business.
Yes.
Talk to me a little bit about how these things can overlap with sleep.
So, yeah, that's a great question. Patients don't understand why I harp on that, but I always tell patients sleep is God's best form of repairing pain.
Yeah. Yes.
But also, knowing my background with sleep, I mean, there's 4 stages of sleep. You have
Mhm.
non-REM sleep and you have REM sleep, and non-REM has 3 stages.
Okay.
So your non-REM 3 sleep, we call it N3 sleep, is your most pain restoring sleep.
Okay.
And so people kind of refer to this as your deep sleep.
Mm.
And it's important that they get into that deep sleep. Now, it
Mhm.
does decrease as we age, of
Mhm.
course. But, getting to that, like sometimes I may find out this person doesn't sleep, and then I try to fix the pain with medication. But if you got them sleep, how much do I really need the medication?
Right.
Can
Right.
the body heal itself?
Right.
And so I find that extremely important to find out, like, about their sleep. Now, I don't send every single person that I see for a sleep study,
Yeah.
but I mean, if I feel like it's warranted, because like pretty much 80% of patients are undiagnosed walking around with sleep disorders.
Yeah.
And so their primary care may be not knowing what to do and maybe covering up with other meds for their sleep. But if we can look into their sleep, then sometimes we can get them help.
Yeah.
And I kind of give that, for instance, like if I have a migraine or a person that has neuralgia or anything like that, and we look at their sleep, I want to send them for an in-lab sleep study and not a home sleep study,
Mm-hmm.
because the in-lab sleep study, they have what's called EEGs. They put the brain waves and know when you're in which stage of sleep.
Got it. Okay.
And so I may capture, maybe they don't have a sleep breathing disorder. Maybe they don't have sleep apnea, but this person's never getting into N3.
Yeah.
Well, there's medicines that actually do pull you into N3. So I'm going to know with that patient that I'm going to use like a gabapentin or a Lyrica because that can pull you into N3 sleep. And so now I'll communicate. I've actually done that with a rheumatologist here, and I had a person sleep studied, and then I call them and I'm like, hey, I'm going to put this person on this. I think you should keep this person on this because they don't get N3 sleep. And they're like, what? Oh, gosh, I would have never known that, you know. So
right.
I would have never thought to sleep study this person.
Yeah.
But we can get like kind of like a strategic plan for this patient and their care when sometimes we look at their sleep.
And I love the idea of addressing. It makes me think of Maslow's hierarchy of needs, you know, where like if you get the foundation laid correctly, everything else starts to sort of fall in line.
Yeah.
So I think that's really amazing.
Yeah.
So one more thing I'm kind of wondering about, as people, specifically women, enter middle age, there's a lot of changes that go on in the body. And I'm wondering, you know, how does that affect them in this whole world of sleep and pain, and kind of what have you seen along those lines?
Well, that's interesting you ask. You know, if you look at the statistics, women are more prone to like trigeminal neuralgia in their menopausal years or postmenopausal years. So they play a huge role in that. And so to me, I feel like, you know, that's even as important as like the sleep part of what I do. And when I look at a patient, if I have a middle-aged woman, then I'm going to talk to them about hormones.
Yeah.
And so hormones are a big deal. And, you know, in November of this past year, they took the black box warning off of hormone treatment.
Oh, wow.
And so it was actually, it was based on, that black box warning was based on a flawed study. It was called a Women's Initiative study. And we've known and it was like over 20 years ago, and we've known that was a flawed study, but nobody's done anything about it. And they have educated the physicians to think that it's going to cause cancer, heart disease, things of that nature. Yeah. Now, granted, some of them would have the synthetic ones, but you have bioidentical hormone treatment. And so that's more of what your body recognizes. So I will check patients and get them, you know, basically get them some help and hope. Yeah. Because sometimes we can actually just do the hormones alone and it helps their pain problem. And so we always work with providers that do bioidentical hormones. And we basically also, I'm also pointing out to those providers, like, we also need to look at their sleep, you know? So, but I mean, because as women, and men too, but I mean, definitely women, as we go through these years of menopause, your progesterone drops off. Well, progesterone is a really good sleep aid. Yeah. And so, and if they're not sleeping, then, you know, if they're getting progesterone, well, then I have patients though on the back end of that they're given all the hormones and their hormones are balanced and they're seeing a hormone specialist and they're still not sleeping. And I'm like, well, then we have other issues. Yeah. So we want to get into that. But hormones do play a huge role. And for men as well. I mean, I definitely will always, you know, check the testosterone and they do have estrogen. Men don't think they have estrogen, but you can have an estrogen dominant male having pain. So they play a big role, and just getting answers. And November helped me because I've been screaming that for a while, but now there's a lot of providers that are getting into hormones because they realize, oh, they weren't bad. We are okay to use them. Yeah. And so that's been a lot easier over the last few months.
Oh, good.
Yeah. Yeah.
So if any of this sounds familiar that we've been talking about, just know that there may be some answers for you. And there may be some options maybe you haven't explored yet. Maybe you're thinking the problem is one thing, but it could be something else entirely. TMJ and Sleep Solutions of Alabama focuses on personalized care to help patients better understand their pain, their sleep issues, and what their next steps are. Make sure you visit their website. This is, again, Dr. Amy Hartsfield from TMJ and Sleep Solutions of Alabama. Make sure you check out their website and get in touch with them if you have questions.
Thanks so much, Ann.
Thank you.